We're going to pick up and start or finish our lecture up with patients that have inflammatory intestinal disorders. And we're going to start talking about appendicitis. And appendicitis is an acute inflammation of the appendix that's most often occurs among young adults. The peak incidence is in those children between 10 and 12 years old. The appendix usually extends off the proximal cecum of the colon just below the ileocecal valve, and inflammation occurs when the lumen or the opening of the appendix is obstructed or blocked. This leads to infection because bacteria will invade the wall of the appendix. The initial obstruction is usually due to hard pieces of feces, but it can also be caused by tumors or other infections. When that lumen is blocked, the mucosa secretes fluids, increasing the internal pressure and restricts blood flow, which will then develop in the pain. So pain in the right lower quadrant is associated with appendicitis. When we think about appendicitis, we want to make sure that we have detailed history taking and tracking the sequence of symptoms, because typically when you think about having gastroenteritis, nausea and vomiting come before the abdominal pain. But when we think about appendicitis, abdominal pain followed by nausea and vomiting can indicate appendicitis. You also want to ask about risk factors because we do see some familial tendencies. When you're doing your pain assessment, we want to make sure that you assess the McBurney's point. And McBurney's point is shown in your book, but what happens with that is abdominal pain that increases with cough or movement and then is relieved by bending the right hip or knees. And if that occurs, what can happen is that could suggest that we have perforation or peritonitis. Laboratory findings don't really establish a diagnosis, but oftentimes we can see an elevation in the white blood cell count, so we'll be cognizant of having that left shift. If the white count is greater than 20,000, that may indicate a perforated appendix. So typically a diagnosis is made on ultrasound, and that ultrasound may show either that there's an enlarged appendix, or we can look at a CT, and a CT might be a little bit more indicative. When we think about interventions, non-surgical interventions is just keep the patient NPO to prepare them for possible surgery. So with surgical management, what they do is called an appendectomy, which is removal of the inflamed appendix. They can do it laparoscopically, which is going to be that minimally invasive procedure that have one or more small incisions near the umbilicus, and then they put the scope through. And patients that have this type of surgery really don't have many post-operative complications. You can also have an open appendectomy, and with an open appendectomy, our patients are at a higher risk for infection because we actually open them up. So the open appendectomy would be called a laparotomy, and that's the surgical approach with a large abdominal incision. And really the only time we see those being done is if there are complications or an atypical appendix. So just remember to pull forward your surgical information from basic concepts, and we'll apply those to dealing with our patients that have had surgical removal of their appendix. Next, we're going to move on to peritonitis. And peritonitis is life-threatening acute inflammation and infection of the visceral or parietal peritoneum and endothelial lining of the abdominal cavity. Typically, people don't just get peritonitis. Usually, peritonitis is due to the effects of some other disease. Oftentimes peritonitis is referred to as the quote-unquote hot belly. So pathophysiology, normally the peritoneal cavity has about 50 milliliters of sterile fluid, and that kind of prevents friction in the abdominal cavity during peristalsis. When the peritoneal cavity is contaminated by bacteria, the body first begins an inflammatory reaction, walling off this localized area to try to help fight that infection. But then this local reaction involves vascular dilation and increased capillary permeability. So with that increased capillary permeability, that allows for transport of leukocytes and subsequent phagocytosis of the offending organism. And if this walling off process doesn't work, so we've had a call to our leukocytes, macrophages are coming to perform phagocytosis to hopefully clean that area up. But if that doesn't happen, what happens then is inflammation spreads, and then contamination of the abdomen becomes really massive, and that's what results in peritonitis. So typically peritonitis is caused by contamination of that peritoneal cavity by bacteria. And a lot of times bacteria can gain entry by a perforation. So a perforation from appendicitis, diverticulitis, peptic ulcer disease, or it could be from an external penetrating wound, so maybe with surgery or a stab wound, anything that invades that area, or could also be due to gangrenous gallbladder or bowel obstruction. And when we have those things occurring, we have to think about what our diagnosis and treatment options are going to be. If we don't treat the patient early in peritonitis, they can end up having decreased circulatory volume, which would result in hypovolemic shock. Peristalsis will slow or stop into response to that severe inflammation. And then sepsis could occur if the toxins or bacteria responsible for peritonitis are also enter the bloodstream. So when we think about our assessment, we need to ask the patient about abdominal pain and determine what the character of that pain is like. Ask about a history of a low-grade fever, typically a fever of about 100. Fever, nausea, vomiting, anorexia. Sometimes they'll guard their movement because of the abdominal pain that they may be having. And then also with coughing or any type of movement, we might see some facial grimacing. You might see marked abdominal distension. And then when you're listening for bowel sounds, you may not hear anything. The cardinal signs of peritonitis are abdominal pain, tenderness, and distension. When we are looking at white counts, the white count is often elevated to at least 20,000 with a high neutrophil count. Blood cultures can be done to determine whether our patient has become septic or not. We need to assess fluid and electrolyte balance, as well as taking a look at renal functions, so looking at the BUN and creatinine, and especially hemoglobin and hematocrit. Typically when we look at abdominal x-rays can assess for free air or fluid in the abdominal cavity, which would be indicative of perforation. So when we think about interventions, IV and electrolyte balance will be important. Some broad spectrum antibiotics immediately after the diagnosis of peritonitis has been made. We'll want to monitor daily weight and INO carefully. We'll probably see insertion of an NG tube to decompress the stomach and intestines, so we want to keep this patient NPO. And by inserting that NG, we'll also have decreased of abdominal distension. If we are thinking about hypovolemia, we'll have an elevated pulse, falling blood pressure. If we would have to do surgery, abdominal surgery may be needed to just repair the cause of the peritonitis. So if the patient is critically ill, they'll postpone surgery until the patient is stable enough to have surgery. But typically we do, and what will be done is an exploratory laparotomy, which is opening into the abdomen, or they can use a laparoscope and look at the tissue that needs to be removed. So if it's due to an appendix, getting rid of that appendix. If we have it from diverticulitis, maybe a colon resection to get rid of those diverticulum. Obviously, if an open surgical wound is needed, infection may slow healing of that incision. So we want to make sure that the wounds are observed carefully. The length of hospitalization will depend on the extent and severity of the infectious process. A lot of times people will respond with IV antibiotics and IV fluids without that multi-system complication. But obviously if the peritonitis is severe enough that it's become septic, then those patients may need to stay with us longer. Once we think about discharge, we want to talk to our patients about antibiotics and analgesics. We also need to consider maybe stool softeners. Next, we'll move on to chronic inflammatory bowel disease, which is ulcerative colitis and Crohn's disease. And really, these are really two of the most common inflammatory bowel diseases that affect adults. When we think about a comparison and contrast, when we think about ulcerative colitis begins in the rectum and proceeds in a continuous manner toward the cecum. Typically, we see it occurring in the ages of 15 to 25 and then 55 to 65. When we think about what's characteristic of their bowel movements, typically 10 to 20 liquid bloody stools per day is normal. For the patient with ulcerative colitis or a flare of ulcerative colitis, complications are going to be hemorrhage as well as nutritional deficits. Frequently, the folks with ulcerative colitis don't need surgery. When you look at Crohn's disease is most often in the terminal ileum, and there might be involvement throughout all layers of the bowel. We see the peak incidence in people of 15 to 40 years old. They have between 5 and 6 loose stools a day, but we don't see blood with them. With Crohn's disease, fistulas are common as well as nutritional deficits. And with Crohn's disease, these people typically have to have some type of surgical intervention. So with ulcerative colitis creates widespread inflammation of really the rectum and the rectosigmoid colon. But as I said earlier, it can extend to the entire colon. Ulcerative colitis is a disease that is associated with periodic remissions and exacerbations. And people with ulcerative colitis are obviously at a high risk for impaired fluid and electrolyte balance because they have the diarrhea, which would include the dehydration as well as hypokalemia. With ulcerative colitis, the intestinal mucosa becomes hyperemic, which means that there has increased blood flow. It becomes edematous and reddened. And as it becomes more severe, that lining can bleed and small erosions or ulcers occur. The patient's stools typically contain blood and mucus, and the patient has a very unpleasant and urgent sensation to defecate. A lot of lower abdominal colicky pain is then relieved after they have gone to the bathroom. The exact cause of ulcerative colitis is unknown, but it could be a combination of genetic, immunologic, and environmental factors. So when you are performing your assessments, make sure you collect data on family history of irritable bowel syndrome. You want to ask about any previous or current therapy for the illness. Talk about the dates, the types of surgery. Think about their nutrition. Ask about food intolerances. When we're completing our physical assessment, the symptoms will vary with the acuteness of the onset. So typically your vital signs are within normal limits. We might see some abdominal distension along the colon. But then if you're thinking if we have a high fever with severe abdominal distension and pain, then you need to think back to peritonitis. Typically with the assessment, patients are very concerned about the frequency of stools and the presence of blood. And it's very difficult to control the symptoms sometimes, so the diarrhea can be really disruptive and stress producing on that person because they feel like they're always on the toilet. With laboratory assessments, since they have chronic blood loss, we want to make sure that we're looking at the hemoglobin and hematocrit. An increased white count, C-reactive protein, or ESR is consistent with inflammatory disease. And we also need to think about the patient's electrolytes as well as albumin levels, because the patients with long progressive disease can end up losing protein in their stool. As far as other diagnostics, we can look at an MRI, and then a colonoscopy may be done to aid in diagnosis. But when you think about the bowel prep that goes along with a colonoscopy, we need to educate our patients that it can be kind of more uncomfortable for them. When we think about drug therapy, really we're looking at aminosalicylates, the glucocorticoids, antidiarrheal drugs, and the immunomodulators. We want to make sure that we do have good nutritional therapy as well as time for these patients to rest. If we would have to deal or go with surgical management, some patients with UC may require surgery to help manage the disease if the medical therapies aren't effective enough. They may have to discuss the fact of having an ileostomy. And so again, refer back to colorectal cancer when they talked about colostomies. With the ileostomy, typically the ostomy drains frequently and the stool can be very irritating. So we want to make sure that the patient knows how to use the pouch system, knows how to protect the skin from all the irritation. With Crohn's disease is a chronic inflammatory disease of the small intestine, the colon, or both. It's most oftentimes associated with the small colon. And really with Crohn's disease, it's like ulcerative colitis, but the disease presents as inflammation that causes thickened bowel wall. And so these folks typically have lesser amounts of stools and they don't have blood present in their stools. Not to say that they won't have blood in their stools, but the bloody stools are more often associated with UC. With Crohn's disease, patients can become very malnourished because they don't have that capability of absorption. So malabsorption, iron deficiency, anemia can be very problematic for these folks. Crohn's disease is made worse by bacterial infections, and so when you're doing your patient's history and assessment, make sure that we talk about any type of bacterial infections, ask about recent unintentional weight loss, the frequency and consistency of the stools. The patients with Crohn's disease definitely need to have a complete psychosocial assessment because the nature is so chronic and there are associated complications that can greatly affect the patients and their families. When we think about Crohn's disease, again, we have to think about dehydration, electrolyte imbalances. Anemia is going to be a common result because of slow bleeding and slow nutrition. These folks will probably also have a decreased albumin levels. Typically, diagnosis will be made with x-rays, MRI, and then colonoscopy. The drugs that are used to manage Crohn's disease are pretty similar to those used with the treatment of ulcerative colitis. The monoclonal antibody drugs have been approved for use in Crohn's disease. So we may see some drugs that inhibit tumor necrosis, decrease inflammation. So Remicade, Humira. So some of those drugs that we also see with RA. Definitely they're going to have long-standing nutritional deficits, so it'll be very important to have nutrition consults. Diverticular disease. Diverticula are little pouch-like herniations of the mucosa through the muscular wall of any portion of the bowel or gut. Most commonly, they are found in the colon. Diverticulosis is the presence of many abnormal pouch-like herniations in the wall of the intestine. And with diverticular disease, we worry about it when it becomes acute diverticulitis, which is the inflammation of the diverticula. With diverticular disease, it can occur in any part of the small or large intestine. The muscle of the colon hypertrophies, thickens, and becomes rigid, and then that causes herniation of the mucosa and submucosa through the colon wall. Diverticula seem to kind of show up and occur at points of weakness in the intestinal wall. And we see it in our aging population because muscle weakness tends to develop as we get older. We can also see these as a result of lack of fiber in the diet. So really without inflammation, diverticula don't really cause many problems. It's when they become inflamed, so when food or bacteria get trapped in the diverticulum, that's when we start to see problems. Diverticulitis can lead into perforation, which would set our patients up for peritonitis. So patients with diverticulosis usually have no symptoms unless pain and bleeding develops. So a lot of times the patient with diverticulitis may have abdominal pain, most often localized in the left lower quadrant. It can be intermittent at first but become progressively worse. Patients typically have an elevation in their temperature as well. If we do not treat early, it can lead into sepsis, hypotension, and hypovolemic shock. So interventions are usually managed on an ambulatory care basis if the symptoms are pretty mild. So oftentimes if we teach patients to alter their diet, avoid nuts, avoid popcorn, corn, anything that was kind of small that would run the risk of becoming lodged in the diverticula. Non-surgical management, we can use medications, so anti-inflammatories, and then broad spectrum antimicrobials, so Motransidil or Flagyl, Bactrim or Bactrim DS or Septra, Cipro. Those are really kind of some good ones that we utilize. But if the patient's pain worsens, then we need to think about giving those IV. We definitely do not want to give laxatives or enemas because they increase intestinal motility, and that will cause increased pain for the patient. It may need that we need to have abdominal rest, so putting the patient NPO or insertion of a nasogastric tube if nausea and vomiting or abdominal distension becomes severe. Surgical management, if the diverticulitis can result in rupture and cause peritonitis, so a colon resection with or without colostomy is also a surgical procedure for patients with diverticular disease. So we have pretty much covered the inflammatory bowel diseases. This picture of the diverticula that I just talked about comes from your book, so you can take a peek at that. This McBurney's point was discussed when I talked about appendicitis. This is a picture view of peritonitis, that severe inflammation of the peritoneum. And then this would be a picture of a colon with Crohn's disease. And another photo of a patient with ulcerative colitis. Refer to this chapter in your book that talks about colostomy and colostomy care, because these are all possibilities of the patient that has inflammatory bowel diseases. So if you are looking at the questions that are at the end of your handouts, when you read this patient, the correct answer is B. Severe ulcerative colitis presents with greater than 6 bloody stools daily and may include fever, tachycardia, anemia, abdominal pain, and an elevated C-reactive protein and or ESR. Patient is admitted to the acute medical unit. Which medication would you question? You would definitely want to question the ibuprofen because it is an NSAID, and NSAIDs increase risk of bleeding. And the answer for this one is D, hyperglycemia. Long-term adverse effects that commonly occur with steroid therapy include hyperglycemia, osteoporosis, peptic ulcer disease, and an increased risk for infection. And this would be B, because Crohn's disease presents as transmural inflammation that causes a thickened bowel wall, strictures, and deep ulcerations that result in severe diarrhea and malabsorption of vital nutrients. Anemia is common, usually from iron deficiency or malabsorption issues. The C-reactive protein may be monitored as a marker of inflammation, albumin to assess nutritional status, and potassium related to losses from diarrhea. If you have questions, please don't hesitate to email me or stop by my office, and I will try to address the questions that you have.